I will now turn the presentation over to Jim for Q&A.
Thank you, Terry Lee. We do have one question for the group. It is addressed to Terry Lee. Is there, can we use the tools in the article at will, as in, do we need permission, I guess? They're asking if they need permission to use the tools that are presented in the article.
They do not need permission. However, I did get permission from the authors of those tools to put those in our publication. So you have two yeses. You can use it, and I did ask for permission anyway, and their answer was yes. There is also a tool that I know a couple of the transitional care units in southwestern Pennsylvania do use. It's from the CDC. They do have a very comprehensive one. However, it is not long-term care specific, but it does work for them.
Okay, we have another question. What is the significance of checking a lactate level?
I have to be honest with you that with lactate levels will increase. What in particular that indicates to the physician, I'm a nurse, so I don't know the answer to that, but it is one of the signs that do need to be related to the physician so they can decide whether or not to implement therapy.
Okay. I'll actually add a little more onto the lactate question. Lactic acid increases as muscles become involved and organs become involved. Basically, we're looking at signs of how acidotic the patient is at that point. It can also dictate the need for fluid therapy. That's something you could potentially draw in the nursing home or in the long-term care unit, but that's more along the lines of when you get to the hospital as far as resuscitation, fluid resuscitation in the presence of sepsis. But it is an indicator of, I guess, how latent or how long sepsis has been going on with the patient. We have another one. What would you say if temperature is low, could this also be a sign of sepsis?
Yes. Hypotension can be a sign of sepsis.
Yes, I would agree that low temperature in the elderly population is just as significant as a higher temperature. Is there a corresponding sepsis-specific care pathway that can be used in conjunction with the Stop and Watch and SBAR tools? There are pathways that are actually published for long-term care online. They're not very easy to find, but some of the acute care pathways can be adapted for long-term care. They're a lot easier to find. Essentially, we're looking at supportive care and making the appropriate decision as to when to transfer the patient. I think the question is asking about how to use the Stop and Watch and SBAR tools. The Stop and Watch tool actually has pretty clear directions on it, and the SBAR tools, it's more of a communication tool. But as far as a specific care pathway, Stop and Watch is more about specific care and identification. Then you'd follow the usual pathway for sepsis treatment. And the SBAR tool is essentially a communication tool that you might be able to model in your long-term care facility.
Okay, Jim, I have a few questions that came specifically to me that I can address.
Okay.
What are the most common pathogens associated with infections that lead to sepsis? The CDC just posted recently that there are 3 common pathogens, and they are Staphylococcus aureus, E. coli, and certain types of streptococcus. Another question is, how often does sepsis occur outside of the hospital? And again, the CDC just posted recently that sepsis begins outside of the hospital for nearly 80% of patients. I found that number to be quite high, but that's what they have found. And the last question that I have, which I think is a really good question, is how can we prevent sepsis from occurring? And we can prevent sepsis from occurring by preventing infections. We can follow infection control requirements such as hand hygiene and ensure patients receive recommended vaccines such as the flu vaccine and pneumococcal vaccine.
Yeah, I'll have to agree with you there, Terry Lee, that, we do in long-term care and long-term acute care, we do have a population of patients that are susceptible to infection, and I think if we're doing everything we can, even including hand hygiene and appropriate infection control measures, that is one very easy, well, not easy, but significant way to prevent infection and related sepsis events. I have a question. Could you review the Stop and Watch tool, and could we have a copy of that tool? The tool is available in the article itself, and as far as reviewing the Stop and Watch tool, I'm not sure we have enough time for that, to be honest with you, but if you review that tool in the article and have questions following that, please contact Terry Lee. We'd be happy to work with you. What are the typical IV fluids that are given to a patient with sepsis? What considerations are given to a patient with CHF? So, Terry, you want me to field that one?
Sure.
Commonly, we're looking at fluid resuscitation, so volume expansion and straight-up fluid. So usually a first response is to give saline. So normal saline, 9%, and in a rate that is appropriate. Usually, if they're hypotensive, pretty much flat out as far as the rate. Considerations with CHF. That's the second part of that question. The considerations with CHF are we're going to fluid resuscitate you first, and then deal with your CHF. If you go into, say, flash CHF, that's something we'll just deal with as far as on the acute care side, inserting an ET tube and breathing for you, if that's the case. But the main goal is to treat the sepsis and worry about the CHF later, because without a blood pressure, the CHF's not going to kill you. So intubation and diuretics post-fluid resuscitation if you go into CHF, potentially intubation with ventilation. Are there different criteria for someone on dialysis? Potentially not really. There are some dialysis cases of sepsis related to bacteremias because of the nature of dialysis. Again, we're going to treat the sepsis and then deal with the sequelae after that, whether it be if you're in the hospital, we could fluid resuscitate you, and if you have issues, we'll dialyze you back down, or the other potential is to run CVVH, which is continuous vasovenous hemodialysis, which is more like a 24-hour dialysis to better control your fluid levels. So again, supportive treatment, aggressive supportive treatment, and then deal with the dialysis issue later. Is the lactate level done with a blood gas? No, it is not. It's a separate blood test. There are considerations for a lactate level, like no tourniquet, and once you're done drawing it, it has to be on ice and sent directly to the lab. It's a very, I guess, for lack of a better word, it's an unstable test, so you have to follow the procedure. So it's probably something that you're not going to draw in a nursing home unless you have the capability to do that there. What considerations with renal failure? Again, we talked about dialysis and a little bit of CHF. Again, we're going to treat you for no blood pressure, basically, and then deal with those issues later. So if someone has renal insufficiency and we hydrate you, but that affects you as far as going to CHF or any other issues, and diuretics don't work, then dialysis is on the table. Would overdiagnosing sepsis work against antibiotic stewardship? Antibiotic stewardship in and of itself needs to be taken into consideration, but if someone is septic, currently what we would do is treat you empirically. If there is an overt sign of infection, which in sepsis it's usually someone that's progressed to sepsis, so that's a yes and no answer, unfortunately. I think that's more of a case-by-case scenario. I do think that sepsis is underdiagnosed in the long-term care arena, and those patients that we see on acute care are usually on an antibiotic to begin with that was not potentially the right antibiotic, so they're on empiric antibiotics without culture, and we've written articles about that. There was a pneumonia article a few months back that addressed that, saying that about, I think it was 80% of nursing homes at this point are using empiric therapy, not guided therapy, in other words, lacking cultures. So I think the bigger question there is with sepsis, is it sepsis or something else, and are we or are we not sending cultures appropriately? So I think that would be that we would need to send more cultures appropriately and then supportively treat the patients using empiric therapy, but also changing therapy to a targeted antibiotic when appropriate. Do we start with zosyn and vancomycin empirically is the last question we'll have time for. That would be up to the treating physician. There are a host of antibiotics, well, not a host, but there are several antibiotics that we could use empirically. And going back to antibiotic stewardship, if you don't have an idea of your antibiogram for your building, you might want to start thinking about if you don't know what an antibiogram is, what is it, and how do you use it to pick drugs or antibiotics that are targeting your antibiogram for your building, not just willy-nilly picking antibiotics out of the air to use them empirically. I would like to thank everyone for some very good questions. I would like to thank Terry Lee for a great presentation on sepsis. If there are questions that we were unable to answer, please email us at the authority, and someone will get back to you with the right answer or resources to answer your question. Again, thank you very much. This concludes our webinar. Thank you very much, and have a good day.